how's acne today? Looks like the sun's gone down.
The ice has been helping, but I get the throbbing pain and subside that I can take my medicine, but my arthritis is acting up. My hand is so stiff I can't get the bottle open.
I didn't sleep very well. A pounding migraine woke me up at 2 a.m. Thankfully, my medication helped. But of course, it has some side effects, like constipation.
Well, you don't need that until I say so.
Describing your pain to a doctor or nurse is important.
They should ask you about your pain, and make sure you are pain scale to find the best way to do it.
If you're in pain, don't tough it out.
Nice shot.
You'll feel better and feel faster.
Some medicines have side effects. Ask your doctor if there's one that's better for you.
Oh, sometimes your pain can be treated with physical therapy, acupuncture, or massage. Aches and pains aren't fun. Speak up about your pain. With the right treatment, you can leave your pain behind.
Just a little bit on what we're going to cover here. How's that sound? I think they're cute. All right, starting with this. We are, our first unit is pain and alterations in comfort. And this unit focuses on pain. And you've covered concepts of this in pharmacology. You've covered it in fundamentals. Make sure that you go back and you look at some of that content if you need to, because some of that content we're not going to be covering again. You've learned it once. So what we're going to do now is build upon this, what you've learned before. So if you have questions about the content, you're not understanding something, I encourage you to call me or email me so that we are understanding the content. So, moving along, how does your experience with pain impact your role as a nurse? Well, your own experiences with pain and observing the experience of friends and family that have been in pain can influence how you will react to a patient's complaints of pain. Now, so can you think of some examples and share your experiences with pain that you have had that may impact your role as a nurse? Anyone want to share?
Well, I know how it is. I had lower back pain for a while, and it just didn't go away. No, I went to PT and got better, but I know how it feels to be in pain.
So how is that, Joe, going to impact your role as a nurse?
You'll be able to put yourself in the patient's shoes when they say they have pain and you may not take it, but
So you can empathize with them, okay? That's good, and you also bring up something where you can put them yourselves in their shoes. Is their pain real or is it not real? So that's something that we're going to talk about also here. Is this person a drug seeker or are they not a drug seeker? Anybody else want to share? Anything?
I remember there was, a patient had a long history of drug abuse, but then was complaining of pain, and every time it was like, okay, it really owns what being a very criminal illness is present.
So they misread their pain, thinking that they were a narcotic seeker probably, when in actuality there was a problem that should have been treated.
And then once there were a patient, the amount of narcotics even touched the pain that was needed, everyone was just like, oh my gosh, this should be done.
Right.
Because it was, it was such a
High amount.
you didn't get close to.
And that's really a good thing because we're going to talk about that as we go through this lecture. People who have drug addiction, tolerance, we're going to talk about all of that stuff as we go through this because as you know, people do react differently to medications. So we'll talk about that. So good. So what does a good nurse do when managing pain? Well, if I think about it, I'm going to assume and hope that everybody here wants to be the good nurse when they graduate. But what does a good nurse really do when managing pain? There's been a lot of focus on managing pain in the past years. One reason is the organization that accredits hospitals, Joint Commission. They expect institutions to aggressively treat pain, reassess that pain, and treat them appropriately. And so what they state is that the patients have the right to appropriate assessment and management of pain, as well as being educated about pain and how their pain is going to be managed. That is huge with the Joint Commission. I don't know if any of you work at St. Joe's, but the state surveys were there again. And one of the things that they looked at was chart audits. One of the things they looked at in the chart audits was pain reassessment. Was that pain being addressed after that pain medication was given? If you're giving somebody PO pain medicine, how often after that should you reassess their pain? An hour, right. An hour is a good time frame for that. If you're giving somebody IV pain medicine, how long should that reassessment be? It could be 15 minutes to a half an hour. Yeah, a good 15 minutes is where you really want to keep that at. So you see, when they did chart audits, they found that those weren't being done. So we didn't readdress their pain, but we gave them more pain medication. So as you see, as we go through this, it's one thing to give pain medication. It's another thing to reassess that pain, see where they're at. And so a lot of this I know that you know, but we're going to dive in depth now into some of these things that we're talking about here. So let's look at a classic definition of pain. McGaffrey is quoted in almost every nursing textbook that I've seen talking about pain. And she states that pain is whatever the person who is experiencing it says it is, existing whenever he or she says it does. So I'm sure if I put this on a multiple choice test, put this as one of the answers on a multiple choice test, you could probably figure it out. But can you put it into practice? Do you think, we've been in clinical situations. We've seen people in hospitals. Sometimes we think they can't have pain at a 9 for that type of surgery. And we're thinking 0 to 10 scale, 9. That's pretty severe pain. Or I had the same injury and it didn't hurt that much. These are things premonitions that we can have that are going to obscure how we're going to treat people who have pain. So it's easy to state a definition, but it's going to be even harder to apply those concepts. And so you may want patients to follow your expectations of pain. I think about having... I've talked to a friend of mine who had a hysterectomy, same thing that I had, and it was horrible. She required narcotics post-op because her pain was so severe. I, on the other hand, went home on ibuprofen. So you see how I'm thinking, I don't know, it was pretty easy. I was wondering why they gave me 6 weeks off of work, whereas she was miserable, requiring narcotics. So you see, I'm thinking as easy as it is, I wouldn't give anybody narcotics to go home on. So you see that our own experiences can obscure what we're thinking about that. So we need to be able to take that definition and remember that it's whatever the patient says it is, and existing whenever he or she says it does. Now there's another definition, and this is from the International Association for the Study of Pain. It includes the fact that pain goes beyond the sensory aspect, but also includes an emotional aspect. And so pain is going to be viewed as a multidimensional experience that has many components. And these components are going to include sensory, emotional, cognitive, developmental, behavioral, and cultural components, all of which may influence pain perception and response. So you can see they say pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So they're looking at it from a different aspect. So let's talk a little bit about who's at risk for undertreatment. And there are several groups, as you can see on the slide, that are at risk for undertreatment of pain. And your textbook also does list these with that. All individuals are at some risk for undertreatment. Reasons vary for undertreatment, but they can be summarized by a lack of health care provider knowledge regarding assessment and treatment of pain. Could be the unwillingness to believe the patient's complaints, and inaccurate information on addiction and the side effects of opioids. Now, you may be surprised by the idea of inadequate knowledge, but I know that some students often think that they don't need to spend a whole lot of time understanding this unit, because pain is a concept that we introduce right at the beginning when we start fundamentals. But this really is an area where there's a lot of inadequate knowledge. When I think about inadequate knowledge, and when I was in my discussion board yesterday, we were talking about this concept. And the one thing I said was I took care of a patient in ICU who was on a ventilator, so he had a breathing tube in, sedated, and but getting pain medication, but never was real comfortable, was always very fidgety. Vital signs were changing, the respiratory rate was up, the heart rate was up, blood pressure was up. When you'd give him the pain medication, he would calm down, but it lasted a very short period of time. And so I called the physician and I said, we have inadequate pain medication here. I really think that we need to put this patient on a PCA pump. He proceeded, it was a new resident, he proceeded to come and sit in my room for 30 minutes and watch the patient. And he looked at me and he says, he doesn't need anything. I says, he's not moving because I just sedated him. I says, but look at his vital signs. Look at how they're changing. Look at how he kind of fidgets a little bit. I says, he is not controlled adequately. And he told me, no, I won't give him anything. Okay, fine. The surgeon came in, who's the attending. And I explained to him what was going on, and he said, absolutely. Wrote me those orders for PCA pump, started him on this, and you could see, right after starting him, giving an extra dose of that, this patient calmed completely down, heart rate, respiratory rate, blood pressure, all came down to a normal rate. So he was sitting there looking and saying, well, he doesn't look like he's in pain, but we didn't look at the whole picture of this. And that resident never liked me after that, but that was okay. But I was advocating for my patient because he was not comfortable. So you see, when we talk about people being healthcare provider knowledge, I mean, it's one thing to have MD behind your name, but it's another thing to be able to adequately assess that patient for what's going on there. So let's talk a little bit about some ethical considerations that exist in relation to pain management. You should star this because this is something you're going to see a few times through the semester. So you can see, and your syllabus also does allude to some of this here on page, and you don't have to look at it now, but I just want you to know that on page 1-5, it does have an overview of some of the ethical terms that we're talking about here. And like I said, you should probably have an understanding of those. But when we talk about those, if the nurse is governed by duty to benefit, a medication, bless you, would be given to relieve pain. So we have that duty to benefit. We're going to give this patient pain medication. Sometimes a nurse is concerned, and I think somebody shared this with us, that the patient will be killed by a dose of medication, and therefore they're going to be reluctant to administer the drug. The nurse is respecting the sanctity of human life with that. Because life is sacred, it must always be protected. But remember, when it comes to pain control, we really need to address that. It's true that many interventions in healthcare are somewhat risky and somewhat dangerous. When you, in third semester now, you're going to learn how to do blood transfusions. I mean, those are just as, can be just as dangerous as anything else. Surgery, anybody who's had surgery, it is full of risks. How many of us have had surgery, and when you went into surgery, the one thing that you wondered is, am I going to be able to come out of this? Am I going to see my family again? We always wonder those sorts of things, when you do that. So everything is full of risk. But still, these risky interventions are done to benefit the patient. We don't do surgery unless you need to have it done. But we're going to treat your pain. And as we're going to learn here, cancer pain is very difficult to treat. And it takes escalating doses. And it takes a lot of pain medication. Enough that we could give one patient dose that would sedate all of us in this room. So you could see that. Now, the American Nurses Association Code of Ethics includes the following excerpt. The nurse should provide interventions to relieve pain and other symptoms in the dying patient, even when those interventions entail risks of hastening someone's death. So, however, nurses may not act with the sole intent of ending a patient's life, even though such action might be motivated by compassion, respect for patient autonomy, and quality of life considerations. What are you thinking when I said that? Who are you thinking of? Giving something to hasten someone's death. Yeah, we could think of Jack Kevorkian, number one, but there was just another one, that young lady in Oregon. Remember? She had that, huh?
With the mother?
The malignant brain tumor that was.
She just wanted her mother to be, I don't know. She wanted somebody to help her mother die?
No, she was the young lady.
Oh.
Yeah, she was very young, just married, and started out with headaches, found out she had this brain tumor that in the end they wouldn't be able to do anything with, and it would eventually kill her. And so she moved from California to Oregon, and I think I have the story right, but she moved in order to, she took a fatal dose of medication. And so that state, Oregon, allowed, she picked her date of, she changed it once, I know that. But she did pick her date of death that she was going to do this. And she wanted to do it before things got too bad. So you can see there's a couple differences there with that. The principle of justice may become a factor if resources are limited. Everybody has equal right to treatment. Think about two patients who need a PCA pump. Who's going to get the PCA pump? Are we going to give it to the person that has insurance that'll cover it, or are we going to give it to the person who doesn't have insurance? Are you going to give it to the person who was driving drunk and hit somebody who's now comatose? Is the drunk driver going to get it, or is the patient going to get it? Do you see, how do you decide who gets it? And so in this case, when you're thinking about the principles of justice, what you need to remember is that it's going to be equal right to treatment. So we're going to have to find another PCA pump. We are not going to make the determination that one needs it more than the other when they both need it. So that's something else to think about. The use of placebos is also an ethical decision or issue. A placebo is an inert substance that's given in the place of something else. And giving that substance is going to deceive the patient by them maybe believing that it's the analgesic. Think about those people with dementia, those people in the nursing home. They don't want to take their pills, right? So we tell them it's something else. What are we doing? Well, this is what we're talking about here. It's an ethical issue. So do we do it? Do we not do it? The use of placebos is generally uniformly condemned by most professional organizations, deceiving the patient. Think about the patients, and we've heard about them. I've never done this to a patient, but you might substitute the Tic Tac for, I don't know, an oxycodone or something. So that patient might be thinking that they're actually getting the pain medicine when they're actually not getting it. That's a little extreme. But I have heard of things happening like that, where we'll tell them, here's another one. You could say you've got this patient who's unruly in the middle of the night and they want to talk to the doctor, so you go grab one of your male nurse friends, bring them in the room and say, this is Dr. So-and-so, and they talk to him like that's the doctor, and then they calm down and they're just as nice as can be. It's really no different than a placebo. You're substituting something for another one, and you're deceiving that person. So you have to be careful about that. That is universally condemned by that. Has it been done? Yeah. Well, not necessarily in a hospital setting, but it could be in an Alzheimer's unit, it could be in a dementia unit, it could be someplace else where this person doesn't really want to take anything, so we tell them it's what it is, and they take it when, yeah, so.
You know, we had a patient who was in pain whenever he gave him pain meds, it didn't work. But then they gave him normal saline.
It worked like a charm. Yeah, I know. That's the same thing, though. You've deceived the patient. We've deceived them.
Well, whenever they got the pain meds, it didn't.
It didn't work. I've seen that. I've seen that happen, where we flushed with saline, and they said, oh my gosh, I feel so much better already. And it's like, but I didn't give you the pain medicine yet. So, yeah. All right, let's do a little review, pathogenesis review. This is really going to begin now our basic review on the pathology of pain, and it's going to include some definitions. When we talk about nociceptors, those are those free nerve endings present in most tissue that act to sense and transmit pain signals. So we're going to talk now about the 4 steps of pain. So make sure that you can put these in your own words. I would star this too, because someplace along the lines you're going to see this again. So the 4 steps include transduction, transmission, perception, and modulation. Transduction is going to be taking a physical signal and changing it into something electrical. Okay? So I think about an arterial line, and I know a lot of you don't know what I'm talking about, but bear with me. We're going to take and we're going to put a catheter into your artery. We're going to take that with specialized tubing. We're going to put it to a transducer, which is going to convert that pulsation to an electrical signal that's going to go up to the monitor, and it's going to display on our monitor a waveform. That's our arterial pressure. Same thing as what we're talking about here. And so when you think about transmission, transmission is going to be carrying or transmitting that electrical signal. So that action potential moves from the site of injury to the spinal cord, not forward, to the brainstem of the thalamus, to the cortex for processing. Then we think about perception. Perception is perceiving the signal in the brain. So that's that subjective experience during which pain is recognized, defined, and responded on by that person. And then we think about modulation. That's modifying the perception. The perception can be decreased or increased through modulation. So when you think about transduction, think about transducer. When you think about transmission, think about transmitting. When you think about perception, think about perceiving. And when you think about modulation, think about modifying. Let's take a look at that for the visual person here. So when you look at the first step, transduction, that noxious stimuli is going to cause cell damage, and it's going to have the release of those sensitizing chemicals. This should take you back to A and P, I hope. Those prostaglandins, that bradykinin, that serotonin, histamine, and substance P. Now these substances are activated. These substances activate those nociceptors and lead to generation of the action potential. So that site of pain. Now you have transmission. That action potential is going to continue from the site of the injury to the spinal cord. From the spinal cord to the brainstem and thalamus. Do y'all remember what the thalamus is? Oh, it's in the brain. Good, Joe. You're really a rocket science today. Okay, so yes, you could call it like the switch. I think of the thalamus as a relay station. All the trains go through there and come back through there. So it's the railway station at the train station. Everything has to come and go through there. So if you have a problem with your thalamus, you're going to have problems with wakefulness. Okay, so I've seen people who have thalamic injuries, and they sleep. So it's a problem there because nothing can go down, and things aren't coming through there. So nothing is happening there. So perception is that conscious experience of pain, and then you see modulation. Those neurons that originate in your brainstem descend to the spinal cord and release substances like your endogenous opioids. Remember what those are? Those are those make you feel good things. They inhibit that nociceptive impulse. So those are endogenous ones. Oh, jeez. get to turn this a little bit. All right, so continuing with pathogenesis, some other terms that we're going to talk about in discussing pain are nociceptive and neuropathic. Now, nociceptive is going to involve damage to the skin, the muscles, joints, internal organs. Neuropathic is just what it says. It involves a problem with a nerve. Often diabetics have this type of problem, this pain, and they suffer from peripheral neuropathy. The pain associated with neuropathy can be very difficult to treat. As in this example, took care of a gentleman a few years ago. He was diabetic, had peripheral neuropathy, and you know they can't feel anything. So it was a hot summer day. It was in the upper 90s, and he had a pool outside. He had a deck to get to his pool, and he had that boards on his deck, which were the ones that very hot when you step on them. So he walked out there, walked onto the cement that was lining his pool. He did some stuff with his pool, and he decided it was time to go take a nap, went back in, and he went to sleep. He woke up, and he had to do something, and he looked at his feet. He says, wow, my feet are kind of swollen. Oh, well. Tried to put his shoes on. His shoes didn't fit. Well, guess what was wrong with him? He was not able to sense that he had burned his feet so bad that they had already blistered. And so in this case, this gentleman, that neuropathic pain that can be so hard to treat, that wasn't there because of his diabetes. And so what happened was he did not have those signals then going back, you see, from the site of injury to the spinal cord, to the thalamus, to the cortex, and back down because of the neuropathy that he had that was so bad. And he ended up having one foot healed and one foot did not heal for months. He ended up having to come in, and they basically, the whole bottom side of his foot, they ended up cutting a chunk out of like this here and packing that every day with gauze. He had wound vac on, all because of his diabetes so bad, and he did not wear his shoes outside like he should have. So that's what you think about when I think about pain. He did not sense the pain, though, because his neuropathy was so bad that he did not sense that. A little bit off, but you can see how that works. Now, let's talk a little bit about the types of nerves that carry pain signals. Pain is carried by A delta fibers and C fibers. A delta fibers are surrounded by myelin, and this will speed the conduction. A delta fibers carry sharp, prickling, piercing sensations rapidly. These are usually found in the skin and the muscle. Now, C nerve fibers are not myelinated, and therefore carry signals more slowly. They're typically found in the muscle, the internal organs, around bones. And people often describe this type of pain as dull or burning. It can be diffuse or just an aching sensation. But remember, this type of pain, the location of this pain is going to be harder to pinpoint because that sensation is so diffuse. So question. A client is stating that he has a sensation of burning, aching, and dullness. Which afferent nerve fibers should be transmitting the pain? C fibers. So the answer is B. Correct. Now let's talk a little bit about the gait control theory. That's something that we will be looking at here. Now, the gait control theory is a classic theory in the discussion of pain, and this may be the first time that most of you have heard about this. Now, in simple terms, pain signals can be blocked by closing the gait. And I've got some visuals to help you understand that. Stimulating another type of nerve will close the gait. The rationale for the effectiveness of pain treatments such as massage, rubbing, ice, are explained with the gait control theory. So when you think about this, small diameter nerve fibers carry your pain. Large diameter nerve fibers carry other signals. If both try to go through the same gate, the large fiber is going to inhibit the small fiber. Think about the poodle and the German shepherd. If they both try to go through the same door, who's going to win? I'm thinking the big dog's going to win. Okay, so think about that. So so if they both try to go through, that larger fiber is going to inhibit the small fiber. So pain is going to be blocked. And so things such as rubbing, massage, and ice can shut that gate because that stimulus then is not there. It doesn't go to the thalamus, to the cortex to be processed and come back down again. Stimulating endogenous opioids can shut the gate. Something like acupuncture or a TENS unit can shut that gate. So that painful response isn't going up that spinal cord to the thalamus again and back down. And descending pathways from higher center in the brain can also control the gate. So your brain can control that gate also. So let's take a look at this pain transmission then. So just as just another view for you to see. So that painful stimuli often originates in the extremities. And if pain is not transmitted to the brain, the person does not feel pain. So there's an area called the substantia gelatinosa there, you can see. And you can see the pain sensations there and the small fibers that are going through there. Okay? And you can see how that's traveling up to the brain. But that substantia gelatinosa is where the gating mechanism occurs. And this is a mass of gray matter that lies on the dorsal side of the dorsal column of your back, your spinal cord, and it extends the entire length of the spinal cord. And it goes into the medulla oblongata. And that functions in the transmission of painful sensory information. So you can see those A delta fibers and C delta fibers are going to be transmitted that way. When the gate is open, pain impulses are going to ascend to the brain. When the gate is closed, those impulses do not get through and pain is not going to be perceived. Remember, what can shut the gate? Acupuncture, ice, massage, a TENS unit, those types of things. So if you sprained your ankle and you elevated it and put ice on it, does it feel better? Right, so that gate is closed. But what happens when you put your foot down and take the ice off? You're in pain. That gate is open now. Them fibers are going to then go all the way through the spinal cord to the thalamus, to the cortex, and then back down. Hey, something's wrong. Let's give you, I don't know, that might be the time where you decide to take your ibuprofen or something. So that's just kind of a visual so you can see how that gating mechanism works. Now, two parts to the gate control theory. Beta fibers in the skin and the brainstem. Now, stimulating fibers on the surface of the skin is not the only way to close the gate. The brainstem is also going to be involved in this. And so the brainstem can send signals down the spinal cord to block pain signals. But it's also possible for the brain to open the gate. And one factor that might open the gate and make it likely for pain signals to reach the brain is going to be emotions, anxiety, depression. Can open that gate, or they can close the gate. Reduce fear with teaching can help with that. So it's going to be important as we go through this to not only address pain, but to address anxiety in your patient also. So that's why typically, especially like in intensive care units or ERs, you may see us giving something for pain, but we're also going to give something for anxiety for patients also. Now, we should also be able to differentiate acute and chronic pain. Now, when we look at acute pain, which is what we're going to look at first here, NANDA uses less than 6 months to differentiate this. Others may use 1, 3, or 6 months. Your Ignatavicus book says acute pain is a duration less than 3 months. Now, the key thing to remember with acute pain is the fact that the body reacts as if it's being attacked. So the sympathetic nervous system is going to kick in. Now, if you don't understand the sympathetic nervous system, I would send you back to your A&P book. But many symptoms of this can be explained by the sympathetic nervous system activity. These symptoms include increased blood pressure, pulse and respirations, sweating, dilated pupils, decreased concentration, restless. Acute pain serves the purpose of warning the person that something is wrong, and it causes a person to take action to correct the problem. The cause for acute pain is usually known, and intensity ranges from mild to severe, and you have overall distress with this. So this is what acute pain looks like. Now, when we talk about chronic pain, it's going to be further divided into non-cancer and cancer pain. Excuse me. Chronic pain serves no biologic purpose. The physiologic adaptations that occur in and the sympathetic nervous system symptoms are not seen. So there is no change in vital signs for somebody with chronic non-cancer pain. The character and quality change over time. The cause of this chronic pain may not be known, and has not responded to treatments or therapies, does not subside after the injury has healed. Some of the things that you can think about are rheumatoid arthritis, lupus, sickle cell anemia, which we'll learn about, fibromyalgia, osteoporosis, and neuropathy. So the key thing to remember here is there's going to be no change in their vital signs. Chronic pain is fatiguing. They have a flat affect, decreased physical movement activity. They withdraw from social interaction, and the pain behavior is often absent. The thing to remember is that the patient may have a flat affect and withdraw from social interaction, but they may not report pain unless they're asked about their pain. Okay? Now, when we look at chronic cancer pain, many patients with advanced cancer will experience this type of pain. The pain can be secondary to tumor, could be secondary to the treatment, nerve compression, bone metastasis, but 2/3 of patients with advanced cancer will have chronic cancer pain. And cancer treatment itself can cause pain, so adequate pain treatment is crucial. Typically, when patients have cancer and we're treating them for pain, we don't ask a whole lot of questions because it is painful. If you think about it, somebody who's diagnosed with cancer and they have remember what happens in your bone marrow, those cancer cells get in there and they multiply and they take over the bone marrow. And so you have that proliferation now of cancer cells. Well, that's happening inside the bone marrow. That might explain why, and I think more of kids with this, why these kids complain of so much leg pain is because of that proliferation of those cancer cells. And then when we're giving them chemotherapy, remember, that itself can cause pain also, but that we'll reserve for fourth semester. But you can see adequate pain control is needed for these kids or adults. Now, we talk a little bit about breakthrough pain also. And sometimes students are very confused about breakthrough pain. So I usually visualize the patient that has chronic cancer pain when I think about breakthrough pain. This person is probably receiving opioids, probably through a paternal way, a continuous infusion. Think about PCA, okay? So they're receiving a continuous infusion of PCA. Or they may have a topical absorption, such as a fentanyl patch. Those are good for 72 hours. Now, or it could be a slow-release form of a medication. OxyContin might be an example of that, or morphine. MS-Contin might be another one. Even though that patient is receiving a continuous infusion or continuous medication, they may still have occasional pain. And so the pain they're having is referred to as breakthrough pain. And in this situation, we are going to give them a pain medication to cover that pain they're having. So I think about the patient that has hip surgery. We send them home, and I'm going to use my mother as an example because this was true. They sent her home on OxyContin and oxycodone. Well, if you can remember from pharmacology, or if you can't, I'm going to tell you, OxyContin is your long-lasting drug, okay? It lasts about 12 hours. So for breakthrough pain, we're going to give you oxycodone that can be taken every 4 to 6 hours. So if you're going to get up and exercise or move around and you're having pain, you're going to take one of those. So that's what we mean by breakthrough pain. Same with somebody who's on a continuous infusion of the PCA pump. So they still may have their PCA button and give themselves a dose every now and then. They've got the continuous infusion, but they still have some breakthrough pain or pain that's not controlled. Maybe it's somebody who had a thoracotomy and they have horrible pain on their side. So, and we've coughed and deep breathed them and they're in excruciating pain. And they won't ambulate now until we give them some. So what we may need to do then is to give them an extra dose, a bolus dose for breakthrough pain. Does that help understand what breakthrough pain is a little bit? Now, there are other ways that we can describe pain. So this is kind of a matching thing with this. So if you think about it, well, let's look at these different types, 5 different types of pain. When you think about visceral pain, what are you thinking about? Yeah, we're thinking about pain from deep organs, exactly. When you think about referred pain, what are you thinking about? Right, it's not where it's supposed to be. I think they say that people that have gallbladder problems, they typically end up with pain. The pain is referred to like right here in the middle of their shoulder blades. Anybody ever have a gallbladder attack? Well, that's what mine was when I had it, and let me tell you, that was painful. But that is referred. That's referred pain. And you're right, it comes from distant away from the area of tissue injury. When we talk about neuropathic pain, we're thinking of nerves, exactly. When we think about somatic pain, we're thinking about, right, muscles, bones, and joints. And when we think about cutaneous, we're thinking about, yeah, superficial pain of the skin. So those are some terms that we can talk about. Now, let's consider some pathology here. You know me and patho. So it's important to control pain for many reasons, including the negative effect that pain has on the body. And so pain causes cardiovascular changes like increased heart rate, increased cardiac output, increased peripheral vascular resistance, hypertension, which all result then in increased myocardial oxygen consumption, so that heart's going to have to work harder. When you think about pain on the respiratory, you're going to have decreased tidal volume. Remember, they're not going to take deep breaths, so atelectasis is going to form, that consolidation in the lungs, that alveoli. So you're not going to have that expansion of those alveoli. You're not going to have that gas exchange taking place there. Hypoxemia, decreased cough, inadequate lung expansion, all of which are going to lead to decreased oxygen saturations. When you think about neuro, reduction in cognitive functions, mental confusion is what happens there. When you think about your GI tract, pain decreases GI mobility. Pain leads to fatigue and immobility, so you can see how the musculoskeletal system is impaired there. Pain leads to metabolic changes. So you have impaired insulin response. You're going to have hyperglycemia. You're going to have increased ACTH, adenocorticotropic hormone. We'll talk about that in our endocrine unit. And cortisol. Those are going to lead to delayed healing, decreased immune responses. You're going to have increased aldosterone being produced, which is going to cause fluid retention. And you can see a prolonged stress response. unrelieved pain results in complications, longer hospital stays, greater disability, and the potentially long-term pain. So that's why we look at the impact of pain and what happens with unrelieved pain. But when we look at that, we need to also consider what the psychosocial effects of chronic pain are. So while we talk about pain as just not physical, there are many psychosocial effects that go along with chronic pain. Loss of employment and income. The person with chronic back pain can't go to work. They end up losing their job. There's no money coming in now. There's depression. Now they're sitting at home. They're doing absolutely nothing. But there's depression, fear, and anxiety. Isolation. Now they're not with their peers at all. They're just sitting at home. Sleep disorders. Now when you're staying home all day, you're sleeping at all times of the days, and what's happening? You're not on a routine schedule anymore. You have marital and family dysfunction. You know, the money's not coming in. So the family now, there's fighting between the husband and the wife about finances. Total family dysfunction. The kids don't need what they need. And you could see that sequelae can go on and on and on. And it interferes with your ADLs. These people with chronic pain tend not to be kept. They don't want to do anything. They don't care what they look like. They don't care if they've stayed in their clothes for the same clothes for the last 3, 4, 5 days, or laying on the couch doing absolutely nothing, sitting in a dark room. So you can see that the effect of this is not just on that person, but it's on the family, and has implications all along the way. Excuse me. There's a website on here, Medtronic, that talks about managing chronic pain. It's not required. I just put it on there. If you want to look at that, you absolutely may certainly go ahead and look at that. Let's also look at what the impact of pain is in children. Now, many also occur in adults with this. But your pediatric textbook lists several physiologic consequences in children that experience pain. The previous slides have shown that many of these has shown that the physical responses to pain also occur in adults. But when you think about children, rapid breathing is going to lead to alkalosis, and we're going to learn that in our acid-base unit. Hyperventilating leads to respiratory alkalosis. Inadequate lung expansion leads to decreased oxygen saturation. Remember, shallow breathing, you're not taking deep breaths, so those alveoli are not being inflated. Inadequate cough leads to secretion retention, which is going to set you up for a pneumonia. You have increased sympathetic nervous system activity that's going to lead to tachycardia, change in your sleep pattern, increased glucose and cortisol. And you have increased metabolic rate and perspiration, which in children we know can lead to an increase in fluid and electrolyte loss, which can be significant because their body surface area is bigger in comparison than to what an adult is. So just to review a couple more terms, we could talk about threshold and tolerance. Threshold refers to how great or little of a stimulus is needed for a person to state they are having pain. And it changes little in a person over time. Tolerance is the amount of pain a person is willing to tolerate. Pain tolerance can be impacted by things about such as how well rested you are. We all know that if we're tired and we're crabby, our pain is worse than if we were well rested. The person who lacks sleep is going to have a lower tolerance to pain. And in general is going to have a lower tolerance to everything, right? So you could see that that's something where that's at. Now, I am going to end this PowerPoint here. I know we're a little bit early, but I'm okay with that because